Parenteral nutrition. The primary goal of parenteral nutrition is to provide patients with adequate calories and proteins to prevent malnutrition and its associated complications. A normal diet provides individuals with an adequate mix of carbohydrates, fats, and proteins for energy and tissue development. Parenteral nutrition therapy must provide patients with these same dietary components: protein in the form of amino acids, carbohydrates in the form of glucose, fats as a lipid emulsion, and water, electrolytes, vitamins, and trace minerals.
Because a number of factors can affect the amount of each of these components that the patient needs, each component of parenteral nutrition must be evaluated and ordered separately. It's important to note that parenteral nutrition should not be used routinely in patients with an intact GIT. Compared with enteral nutrition, it causes more complications, does not preserve GI tract structure and function as well, and is more expensive.
There are two types of parenteral nutrition: partial parenteral nutrition and total parenteral nutrition. Partial parenteral nutrition supplies only part of daily nutritional requirements, supplementing oral intake. Many hospitalized patients are given dextrose or amino acid solutions by this method. The total parenteral nutrition supplies all the daily nutritional requirements. TPN can be used in the hospital or at home. Because TPN solutions are concentrated and can cause thrombosis of peripheral veins, a central venous catheter is usually required.
So what are the indications of total parenteral nutrition? General, total parenteral nutrition therapy is indicated for patients requiring long-term, more than 10 days, supplemental nutrition because they are unable to receive all daily requirements through oral or enteral feedings. Requiring total nutrition because of severe intestinal dysfunction or inability to tolerate enteral feedings. Specific, TPN therapy is part of routine care in patients who cannot eat or absorb nutrients through the GI tract because of massive bowel resection, diseases of the small bowel, radiation, enteritis. Malnutritioned patients undergoing high-dose chemotherapy or radiation therapy, patients with severe malnutrition or non-functional gut, malnutrition patients with AIDS who have intractable diarrhea. When enteral feeding cannot be established, TPN is usually helpful after a major surgery, in patients with enterocutaneous fistulas, in patients with inflammatory bowel disease, in patients with hyperemesis gravidarum, in patients with small bowel obstruction secondary to adhesions. Contraindications of TPN include allergy to any of the components, volume overload caused by heart failure or renal failure or liver disease.
What is the nutritional content in TPN? Fluid requirements. Before the TPN is initiated and throughout the duration of the TPN therapy, careful assessment of fluid status is imperative. Often between meeting the caloric, proteins, and electrolyte needs, sufficient if not excessive water is provided. However, in circumstances where water needs are elevated or reduced, or the patient's body size is abnormally large or small, fluid requirements become an extremely important consideration. Fluid requirements increase in fever, fistulas, diarrhea, and nasogastric suctioning, and decrease in renal failure, congestive heart failure, and cirrhotic ascites and pulmonary diseases. Calorie and protein requirements. Since protein is needed for tissue synthesis and repair, amino acids are not routinely used for basic energy requirements. Carbohydrates are usually used as the main source of energy. However, in the hypermetabolic patients with excessive energy needs, protein may be utilized for energy. Macronutrient requirements like calculating the calories kilocalorie per kilogram per day, the proteins of gram kilogram per kilogram per day, and the dextrose rate and the fat. These calculations of the macronutrient requirements have a different range in infants, children, adolescents, and adults. Macronutrient requirements. Electrolytes. Electrolyte doses in a PN order must be individualized for each patient, as each electrolyte plays an important role in the body homeostasis. All the levels should be within normal range. The electrolyte requirements of sodium, potassium, magnesium, calcium, phosphorus, chloride, and acetate. Vitamins. Vitamins are an essential component of the patient's daily PN regimen because they are necessary for normal metabolism and cellular function. Occasionally, a patient will need to be treated with a therapeutic dose of a vitamin. Since long-term patients are susceptible to developing vitamin deficiencies, they are more likely to require vitamin therapy. Trace elements. Trace elements are metabolic cofactor essential for the proper functioning of several enzyme systems. As with vitamins, long-term PN is more likely to be associated with deficiencies, therefore additional trace mineral supplementation may be required in these patients. The daily trace mineral requirements of copper, manganese, zinc, chromium, selenium, molybdenum, iodine, and iron. Trace minerals administration should be decreased or withheld in patients with impaired ability to excrete them. In patients with renal impairment, selenium, chromium, and molybdenum may be omitted. In the patients with severe hepatic disease, manganese and copper may be withheld.
TPN solutions vary depending on other disorders present and patient age, as for the following. For renal insufficiency not being treated with dialysis or for liver failure, reduced protein content and a high percentage of essential amino acids, reduced trace elements, and certain electrolytes. For heart or kidney failure, limited volume liquid intake. For respiratory failure, a lipid emulsion that provides most of non-protein calories to minimize CO2 production by carbohydrate metabolism. For neonates, lower dextrose concentrations 17 to 18%. How to start a TPN? Because the central venous catheter needs to remain in place for a long time, strict sterile technique must be used during insertion and maintenance. The TPN line should not be used for any other purpose. External tubing should be changed every 24 hours with the first bag of the day. Dressings should be kept sterile and are usually changed every 48 hours using strict sterile techniques. If TPN is given outside the hospital, patients must be taught to recognize symptoms of infection and qualified home nursing must be arranged. The solution is started slowly at 50% of the calculated requirements, using 5% dextrose to make up the balance of fluid requirements. Energy and nitrogen should be given simultaneously. Insulin is added directly to the TPN solution. The amount of regular insulin given depends on the plasma glucose level. If the level is normal and the final solution contains 25% dextrose, the usual starting dose is 5 to 10 units of regular insulin per liter of TPN fluid. Monitoring TPN receiving patients. Progress should be followed on a flowchart. An interdisciplinary nutrition team should monitor patients. Weight, CBC, electrolytes, and BUN should be monitored often. Plasma glucose should be monitored every 6 hours until patient's glucose levels become stable. Fluid intake and output should be monitored continuously. When patients become stable, blood tests can be done much less often. Liver function tests should be done. Plasma proteins such as serum albumin, prothrombin time, plasma and urine osmolality, as well as calcium, magnesium, and phosphate should be measured twice per week. If possible, blood tests should not be done during glucose infusion. Full nutritional assessment, including BMI calculation and anthropometric measurements, should be repeated at 2-week intervals.
Complications. About 5 to 10% of patients have complications related to central venous access. The catheter-related sepsis occurs in probably more than or equal to 50% of the patients. This can be reduced by proper patient education and careful catheter placement. The glucose abnormalities, hyperglycemia or hypoglycemia, or liver dysfunction occurs in more than 90% of patients. The glucose abnormalities can be avoided by monitoring the plasma glucose often and adjusting the insulin dose in the TPN solution and giving subcutaneous insulin as needed. The hepatic complications include liver dysfunction, painful hepatomegaly, and hyperammonemia. They can develop at any age but are most common among infants, particularly premature ones whose liver is immature. The liver dysfunction may be transient, evidenced by increased transaminases, bilirubin, and alkaline phosphates. It commonly occurs when the TPN is started, can be reduced by reducing the protein intake. Painful hepatomegaly suggests fat accumulation. Carbohydrate delivery should be reduced. Hyperammonemia can develop in infants, causing lethargy, twitching, and generalized seizures. Arginine supplementation at 0.5 to 1 millimole per kilogram per day can correct it. If the infants develop any hepatic complication, limiting the amino acids to 1 gram per kilogram per day may be necessary.
Abnormalities of serum electrolytes and minerals should be corrected by modifying subsequent infusions or, if correction is urgently required, by beginning appropriate peripheral vein infusions. Elevated BUN may reflect dehydration, which can be corrected by giving free water as 5% dextrose via a peripheral vein. Volume overload suggested by over 1 kg per day weight gain may occur when patients have high daily energy requirements and thus require large volume of fluids. Metabolic bone disease or bone demineralization, osteoporosis or osteomalacia develops in some patients given TPN for more than 3 months. The mechanism is unknown. Advanced disease can cause severe periarticular, lower extremity, and back pain.
Adverse reactions to lipid emulsions. Example dyspnea, cutaneous allergic reactions, nausea, headache, back pain, and sweating and dizziness are uncommon but may occur early. The temporary hyperlipidemia may occur, particularly in patients with kidney or liver failure. Treatment is usually not required. The delayed adverse reactions to lipid emulsions include hepatomegaly, mild elevations of liver enzymes, and splenomegaly, thrombocytopenia, leukopenia, and especially in premature infants with respiratory distress syndrome, pulmonary function abnormalities. The temporary or permanently slowing or stopping lipid emulsions infusion may prevent or minimize these adverse reactions. The gallbladder complications include cholelithiasis and cholecystitis. These complications can be caused or worsened by prolonged gallbladder stasis. Stimulating contraction by providing about 20 to 30% of the calories as fat and stopping glucose infusion several hours a day is helpful. Oral or enteral intake also helps. Treatment with metronidazole, ursodeoxycholic acid, and phenobarbital or cholecystokinin helps some patients with cholestasis.
Key points. Consider parenteral nutrition for patients who do not have a functioning GI tract or who have disorders requiring complete bowel rest. Calculate requirements for water, energy, amino acids, essential fatty acids, vitamins, and minerals. Choose a solution based on patient age and organ function status. Different solutions are required for neonates and for patients who have compromised heart, kidney, or lung function. Use a central venous catheter with strict sterile technique for insertion and maintenance. Monitor patients closely for complications and prevent them.
Pharmacist role. Indeed, the clinical pharmacists play an important role in preparing and monitoring the TPN in hospitals. One of the pharmacist's roles is, prior to the initiation of the TPN therapy, pharmacists review the chart, then conduct a physical and nutritional assessment of the patient. 2. Furthermore, pharmacists order any laboratory tests needed for further assessment of the patient and uses these results to classify the patient nutritional status. 3. Pharmacists calculate the amount of macronutrients that the patient need. And 4. At the formulation state, the hospital pharmacist must ensure both a germs-free environment and a good aseptic technique.
Pharmacists have to determine compatibility and the stability of the mixture. All TPN patients are pharmaceutically monitored. Pharmacists report any symptoms or complications the patient experienced. The electrolyte status is to be monitored by the pharmacists as well.